Let me begin this update with an overview of managing pain in chronic rheumatic disease. I would probably stress more on dealing with chronic pain rather than acute pain, which all of us do in and day out in our clinical practice. The pain is the most common cause for medical consultation. We all associated pain with nociception, but there is definitely a group of patients present with pain which is not due to nociception or inflammation or injury. This pain is called non-nociceptive pain. Neurogenic pain and psychogenic pain are classic examples of this. In the same spectrum, some of the pain closely relate to the physical injury in the tissue, and people can have pain even without any obvious damage to the physical structure. So in this situation, brain would act like a virtual reality system, and believe me, both pains would result in suffering, and they are subserved by different areas of brain and so require different strategies to deal with. So pain is a complex symptom that dominates the clinical feature of most of the rheumatic diseases, and it can be the overriding determinant of quality of life. And for many patients with chronic pain, it is not only a symptom, it becomes the disease. I briefly touch upon the difference between acute and chronic pain. Acute pain is an early biological warning sign. The patient hurts because it has got a biological benefit for him, and it signals tissue damage and its body's way of telling us to slow down. Example, fracture pain. If you have a toothache, body tells us not to use that tooth for mastication. So this is essentially an important physiological mechanism to preserve the human being. But the chronic pain is not that simple. It has got multiple dimensions. The physical problem can be this big or very small, and so many other components like distress. The patient who has a family history of rheumatoid arthritis, even if they get a mild pain in their fingers, they become so distressed that this minor pain becomes so big and enormous. Until they get reassured that it is not rheumatoid arthritis, they suffer enormously. So the pain here may not equate with the amount of suffering patients have. So many other factors, illness behavior, social interaction, the knowledge the patient has about the disease through media, through other doctors, other patients, public, they come to a doctor with a concept about what is the disease. So all these things cloud their interpretation of pain and the physical symptoms, and the suffering can vary enormously from patient to patient. So again, probably we'll try to differentiate between acute pain and a chronic pain, because this is absolutely essential for a clinician to have these differences clearly made out, because the treatment strategies are totally different. Acute pain, you can call it as eudynia. It's a physiological pain. It serves biological function. It has got a clear-cut relationship to the amount of injury and nociception. The amount of pain is usually proportionate to the physical injury. More severe the injury, probably the more severe the pain is, and they have a natural tendency to recover. But look at the chronic pain. We can call it as maldynia. It's a pathological pain. It has no biological function. Chronic pain is a useless pain. It doesn't serve any purpose. It is an aberration. It is a disease, and it is often dissociated from the tissue damage and nociception. And the pains are generally disproportionate to the amount of physical finding, and somehow it has got a knack of self-sustaining itself and perpetuate even in the absence of an ongoing tissue injury, and it generally exceeds the expected duration of recovery. So in other words, chronic pain is not a continued acute pain or an untreated acute pain, and if the pain remains uncontrolled, in some patients who are vulnerable, it can alter the CNS permanently to become a painful memory, even long after the original insult has gone. This is the painful memory which keeps giving the pain sensation to the patients. This is the characteristic of chronic pain. Some of the patients with rheumatoid arthritis and osteoarthritis, they continue to have an ongoing inflammatory process which can lead to an ongoing pain. Some of them would probably are continued acute pain. But many patients who have chronic pain syndromes belong to this group. So what happens when somebody has a chronic pain? They generally get into a whirlpool of events which leads them from a good pink of health to a poor health status. Pain would lead to inactivity. Because they are inactive, they have reduced exercise capacity, they become deconditioned, and that leads to more symptoms. The more rest they take, the more deconditioned they became. Whenever they start moving, it starts hurting. That reinforces their pain behavior and leads to depression, lethargy, and further inactivity. They get into the whirlpool of pain and more pain and more pain and more pain. They end up suffering. So what are the side effects of chronic pain? We are all bothered about side effects of the disease. Side effects of chronic pain are, there are few characteristics which determine the patients with chronic disease. So because I told you earlier, chronic pain is a disease by itself. Very difficult for one to identify the cause for pain after many years of chronic pain. So the patients generally are irritable, they can be depressed, they have become insomnic, they always come with a huge file and a big carrier bag full of old MRIs and CT scans and whatnot. And most of them lose job, most of them lose self-esteem due to various reasons because they need help for most of the day-to-day activities. The moment they require help for day-to-day activities, including self-care, their self-esteem becomes very low. They become socially isolated. They don't want to be seen as sick patients outside. They don't go to marriages. They don't go to functions. And sometimes it leads to marital discordance. It's difficult to put up with somebody who has chronic pain and complain always. And they have sexual difficulties, reduced quality of life. And patients who have chronic pain due to any cause, they tend to die 5 to 10 years earlier than patients who don't have much pain. So these are all the side effects of chronic pain. So it is essential for us to recognize these patients and get them back to near normalcy, not pain-free state, but near normalcy. Coming to management principles, we need to balance the side effects of the disease, which I have told you, and pain, along with the side effects of the drugs. Most of us are too worried about the side effects of the drugs, but in that process we ignore the side effects of the disease. And I personally feel that therapy should assist these patients with chronic disease to manage their own pain. Both pharmacological and non-pharmacological means of pain relief is not a pain cure, but it helps them to manage their pain better. We have to assist them to manage their pain better. And my sincere request to my medical colleagues is we should not perpetuate the myth of harmful drugs. Yesterday I saw a patient who is a working lady who has taken 1 month leave and has to get back to work otherwise she would lose her job. She is a diabetic of 30 years old. Her creatinine is 0.5. There is no proteinuria. But her diabetologist has told, don't take painkiller, it is a poison. And this girl cannot even walk. She has to use two people's help to walk. And the moment we gave one meloxicam 15 milligrams, she could walk. And she has only chikungunya and chikungunya sequelae. Probably 10-15 days of painkiller would not have killed her. Definitely would not have bothered her kidney, because she is a young woman with a very good renal function. So we have to be very careful with the words we use with the patient. And when we terrorize patients with the terminologies like this about painkillers and steroids, they don't take it even when they require. I have lost a patient with SLE who came to us with severe CNS lesion, who refused to take steroids and died at the age of 25 because she is scared of side effects. If she has taken steroids, she would have lived to see the day for another 20 years. So I would request you not to perpetuate the myth of harmful drug. Drugs are definitely have harmful effects. We have to be careful with we give, but don't demonize it. And patients seem to endure and suffer pain, as I have told you, rather than seek relief. So pain management principles would include pharmacological and non-pharmacological measures. We should not forget non-pharmacological method. We can reduce pain by non-drug means. We should utilize these harmful methods as much as possible so that we help our patients in different ways, thereby cutting down the medication related side effects as well. And in most of the chronic rheumatic diseases, there is no cure in sight. Probably another 10 years we are not going to see a cure for rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. So we need, as a doctor, rheumatologist or an orthopedic surgeon or a general physician, we need to work on two axes or two lines. The one is to control the underlying disease. Whatever medicines you use to reduce pain will not help unless the rheumatoid arthritis comes under control. So we need to manage the axis 1. Simultaneously, we should not ignore the axis 2. We have to manage the pain. The pain relief is the philosophy behind most of the medical systems. The entire medicine as a field developed to alleviate the suffering of the human beings. And we have to take care of this aspect of pain management. First, what are the non-pharmacological methods we can efficiently use to manage pain? Exercises. A fit person is less likely to suffer more. A fit person who gets into a fitness mode generally gets into good health habits, who exercise regularly, who walks regularly, who jogs regularly, who exercise regularly. Generally they are much more fit, more conditioned. Even when they get acute pain, they are unlikely to take 24 hours or 48 hours, more than beyond that amount of rest, and get back to normalcy very soon. So exercises would result in a stronger muscle, much fitter person and less amount of pain. Even in osteoarthritis, simple quadriceps exercise can reduce the pain by 10 to 15%. Weight loss, again, in osteoarthritic patients, 5 kg to 10 kg weight loss would result in about 20% pain relief. It also reduces the risk of osteoarthritis from developing in the other joint. So we can also use assistive device by using a walking stick. If somebody has a very severe knee pain in one knee, and if they use the walking stick on the other knee while walking, 50% of the load is taken by the walking stick. They put less load on the affected knee, and thereby pain can be reduced. Only thing is, most of the patients who are 70 years, 75 years, they say they are not old enough to use a walking stick. There is a big taboo about this. We have to educate them about it. It is not shameful to use a walking stick. And occupational retraining, slightly changing the way we sit in our computer tables, in your office tables, can make a difference in pain relief. If you sit in a stool and see patients, probably you will have back pain. You use a chair with a back support, probably use a pillow behind your back pain is gone. So you don't think about back pain, you can think about the patient. And joint protection, again, a simple change. If the patient can afford to spend 2,000 to 3,000 rupees and change their Indian toilet into an European toilet, they can reduce the burden on the knee joint and thereby reducing the pain by 20 to 30%. These are simple measures people can use to reduce their pain. Rather than popping up one Overon 3 times a day to relieve the pain, they can spend few thousand rupees to convert their toilets into an European closet. And physiotherapists efficiently use thermal modalities like heat in many forms. Shortwave diathermy, ultrasound, they are all heat modalities. They also use wax baths in rheumatoid arthritis. Even simple putting your hand in hot water when the pain is more. As soon as if you are stiff in the morning, due to any reason, osteoarthritis, rheumatoid arthritis, put your hand or feet in warm water for 5 minutes, you feel better. These are simple measures all of us can do without any need for medications or any training. Cold is a very useful pain modality in acute pain. And TENS, transcutaneous electrical stimulation. Acupuncture is an useful pain modality. It has got some scientific evidence to say that it may be useful in back pain, osteoarthritis, and some of the non-specific pains like myofascial pain syndrome, facial pains, trigger point related pains. So this is, if you have a trained acupuncturist, you can utilize his service for relieving some of the pains. It is a non-pharmacological mode, has got very minimum side effects unless the needle enters into the lungs or any major vessels. So the person who uses acupuncture should know the anatomy well. And some of the clinical psychologists can use imagery techniques and cognitive behavioral modification to change the way we think about the pain. I'll tell you an example. I have a patient who kept on telling that I cannot make 10 chapatis at a stretch. When I make 10 chapatis, I start getting pain. I can do 5 or 6, but 10th I start severe pain. So simple, I ask them to change the way they think about the disease. Rather than thinking that they cannot make even 10 chapatis a day, do 5 chapatis, just leave the chapati, whatever what you call it, chapati mane there, stretch yourself, go and watch a movie or watch a song in your TV and come back and finish the 5. Then you will not feel that you are not able to do 10 chapatis. You can still, as long as you do that 10 chapatis, take little longer time, doesn't matter. If they start thinking like that, that ceases to be a problem. If that ceases to be a problem, they are not unlikely to come back to the doctor. They require less medications. I tell them many a times, don't come to the doctors, we will make you patients. If you can manage your simple pains, you manage yourself. If you cannot cope up with it, come back to us, then we will treat you. Otherwise, you keep on coming back to us, we have nothing else to do, and at the end of the day, we will start giving you some Overan, some medicines and make you a patient. Then you become dependent on us to relieve your pain. Then comes the last but not the least, spend few minutes with the patient to educate the need for pain medicines, need for these exercises, need for managing the pain themselves. Then coming to the pharmacological means, in a simple non-inflammatory pain, we should always try paracetamol first. In an acute painful state, we can use up to 8 simple crocins a day. Though it looks like a big thing, but many people are scared, 8 crocins, can I take 8 crocins? But we have to tell them that for a short period, if you use it for a week, it is harmless. But if you are going to use crocin on a long-term basis, you should not probably exceed 2500 milligram, that is 5 tablets of standard paracetamol. And it is safe. Nobody clearly knows how it acts. Probably it acts in the brain through a COX-3, putative COX-3 enzyme. It has got a central nervous system serotogenic effect. Probably it may be acting on cannabinoid receptors as well. Cannabis is our ganja or hashish. Body has got a receptor for cannabinoid materials. Probably paracetamol may have an effect on that as well. It is not tremendously effective, but in people who respond well, it is a safe drug to continue. And then comes the next group, weak opioids, drugs like codeine, dextropropoxifen or proxy-1, tramadol and tramadol paracetamol combination. They have a good safety record, but tolerability seems to be a problem. Many patients have sedation, giddiness, nausea, vomiting, constipation, and there is a small fear of addiction. I have seen people who are addicted to proxy-1 and addicted to codeine, but relatively rare. There is a way of reducing the side effects of tramadol paracetamol combination. Many drugs are available, Ultrasac, Ultraset. Probably starting them slowly with half tablet every 12 hours, gradually increasing it to a maximum of 2 tablets 3 times a day. Many people seem to tolerate it better. This is a much safer analgesic drug rather than to keep somebody on a regular NSAIDs. Then coming to stronger opioids, morphine, pethidine, pentosacoine, fentanyl patches are some of the drugs which are available. But problem is it is not widely available, restricted availability, not everybody can prescribe it, and there is an inherent reluctance from the doctor's point of view to use it in non-cancer pain. In cancer pain, all of us have accepted that morphine is useful, morphine should be given. But if I prescribe morphine for a chronic back pain patient who is suffering a lot, probably every family doctor who sees my prescription is going to, Dharmanand must have gone mad. He is giving morphine for a non-cancer patient. That's what even I would have felt like that and some time back if I have not been trained in chronic pain management. There is a huge reluctance, and also we all have limited training in the usage and titration. Most of us are not confident in using morphine, how much to use, how to titrate the dose, how to change it from acute preparation to chronic preparation. This is a problem, and definitely there is an addiction potential. There is about around less than 5% of the patients who are given morphine for non-cancer purposes become addicted to it. So 95% don't. That's a good news. And it also has got a big side effect profile. So we generally don't use it much, and usage requires expert referral. NSAIDs, most popular, widely used, and it's demonized by media and public and also doctors. It's effective for nociceptive pains. Most of the osteoarthritis, rheumatoids do well with non-steroidal anti-inflammatory drugs. Diseases like ankylosing spondylitis require NSAIDs for long-term management because disease-modifying drugs are not tremendously useful. Not all of us can afford anti-TNF medication. So ankylosing spondylitis, NSAIDs are the cornerstone of treatment. They should be on regular NSAIDs. And we have many choices. We are spoiled for choices now. We have at least 20 to 30 different NSAIDs. They are all conventional NSAIDs, selective, preferential, COX-2 inhibitors. Every drug company says that my COX-2 inhibitor, my preferential inhibitor is superior to the others. And the efficacy is same at comparable dose. But the analgesic effect can vary. There are few drugs which are probably a little better analgesics. Nimesulide is a better analgesic. It's an anti-inflammatory. Some of the drugs may not be as strong analgesics. So individual preferences can be there. One person can respond to diclofenac, another person would respond to piroxicam. So we have to choose the drug by trial and error. And I have to stress that there is no absolutely safe NSAIDs. And don't be foxed by industry's clever marketing strategies. All NSAIDs are almost same. And all carry a huge list of side effects. None is totally superior. Yesterday, I was talking to an orthopedic surgeon. The patient had a huge leg edema and a high blood pressure and a borderline renal status. His interpretation, I have put her only on aceclofenac. This should not be harmful, no sir. So the people interpret that some of the newly marketed drugs are safer than the conventional drugs. Yes, there is a safety advantage with regards to gastrointestinal side effects. COX-2 inhibitors are much superior in gastric safety, peptic ulcer related side effects. But with regards to renal, hepatic and cardiac toxicity, all drugs are similar. And is there any way to use it safely? We need to avoid. If you want it to be used safely, you have to avoid it in patients who are at a risk of developing side effects. Elderly patients who have borderline renal status, cardiac, somebody who has had an ischemic heart disease, who are diabetics with cardiac risk factors, hepatic dysfunction, these are the patients better to avoid. And if a patient has got severe acid peptic disease, who have bled through the ulcers before, we have to avoid NSAIDs as much as possible. Even if you decide to use it, we have to monitor them very closely. Probably every month you may have to do a creatinine, every month you have to watch for side effects. Use COX-2 inhibitors or along with proton pump inhibitors if gastrointestinal side effects are a concern. Always get a creatinine as a baseline and try to do a GFR. Some of the drug companies do give a GFR calculator, which is a handy calculator, or you can download GFR calculator, Cochrane-Croft calculator through the internet into your computer. Simple: age, weight, creatinine value and a sex. If you enter this, it gives you a creatinine clearance. It calculates, computer calculates. You need not calculate. Believe me or not, a creatinine value of 0.9 in a 45-year-old, 50-year-old woman who weighs 45 kg, her creatinine clearance will be less than 60. That means, by definition, she is in a chronic kidney disease. But if you look at the creatinine value per se, absolute, 0.9 looks normal to us. We would end up giving NSAIDs. But if you calculate estimated creatinine clearance, her GFR would be on borderline. They will be already 59 or 60. That would put her into the definition of chronic kidney disease. If you go to a nephrologist, they will call it as chronic kidney disease and probably start giving hepatitis B vaccines and prepare them for dialysis in future. So we have to be careful with these patients. If you decide to give NSAID in a long term, in a well patient, normal creatinine, absolutely normal, monitor creatinine every 6 months. Those who are having borderline creatinine, probably they require monitoring much more closely, maybe monthly, maybe 2 monthly. Monitor blood pressure. Every doctor who uses NSAID on a regular basis should check the blood pressure of the patients, because this can increase the blood pressure it can also interfere with the blood pressure control of some other drugs like atenolol and calcium channel blockers. And look for leg edema. And if somebody is on NSAIDs and they also require aspirin for cardiac protection, don't stop aspirin, because if you stop aspirin, somehow the mechanism the prostaglandin mechanism is favored towards thrombogenesis. They are prone to develop ischemic heart disease. So don't stop aspirin. If required, give them an additional proton pump inhibitor. And the last but not least, if should use NSAID only if needed. Try to use paracetamol, your all other weak opioids before you decide that patient needs NSAID and nothing else. And as and when usage, SOS usage may be safer whenever it is allowed. And always consider non-pharmacological and other pharmacological modalities for pain relief. This is the last group of drugs I am going to talk about. There is a concept called co-analgesic. These are not the usual painkillers. If your patient's pain it doesn't respond to your NSAIDs, somebody comes to you with severe pain in the hands, you give them Brufen, Overon. Don't keep on changing it. Find out, spend 1 more minute, what is the nature of the pain. If the pain has got a neurogenic quality, they have burning pain, they have a paresthesia, they have a sharp shooting kind of pain, lancinating pain. This is not a nociceptive pain. Probably they may be having a neuropathy, a diabetic neuropathy or something similar. In this situation, probably adding a tricyclic drug or a drug in this group or an anti-epileptic can make a huge difference to the pain relief. And in the management process, never forget the axis 1. As I told you, maintain the disease with use oral steroids. Intra-articular steroids can be an efficient pain modality in osteoarthritic patients. This slide tells us that different drugs act through different mechanism in the brain. So the drugs we use helps us to modify the way we perceive the pain. Morphine does it. Some of the tricyclic antidepressants helps us to modify the pain perception. Anti-epileptics modulate the pain transmission and also enhance the descending inhibitory pathways. NSAIDs and analgesics work probably more in the peripheral level. So sometimes you may have to use polypharmacy in the chronic pain. Polypharmacy generally is a bad word, but in some of the chronic pain patients we may have to use polypharmacy because we may have to use different drugs which act through different modalities. This may help us to reduce the side effects of the drugs. This allows us to use smaller doses of the same drugs. And I have to tell you that despite all the efforts, even in a strong pain clinic, in a typical pain clinic abroad, the pain relief can be inadequate due to side effects of the drugs and also probably due to inadequate effort from the physician's side. So again, my last but one slide, acute pain is a symptom but chronic pain is a disease. So if somebody comes to you with 6 years of back pain, it is futile to search for a cause. Probably you have to treat the pain and regard pain as a disease. And don't worry if you cannot manage everybody's pain. Sometimes it's extremely difficult to treat some of the chronic pains. We have to accept defeat and see if somebody else can do a better job. Probably we have to refer. And my last slide is, it is extremely difficult to treat a patient in whom pain has become a way of life. Thank you very much. It can be extremely painful, particularly in early stages, and sometimes pain can continue for months together. There is no specific guidelines. All NSAIDs are, as I told you, are the same. There is no real preference over the one NSAID over the other. You look at the patient, choose the safest NSAID for the patient, and you use them adequately for about a week or 2. If they don't respond well, we can even use a single dose of steroid injection, which can be very useful, and also simultaneously use chloroquine, which seem to reduce the duration of the illness.
We have a pain for a long time, years, 3 years, 4 years, analgesics daily. Which analgesic do you recommend for a patient who needs for more than 2-3 years? The safest drug which doesn't interfere with your DMRD profile also. So you have one DMRD or two DMRDs and one analgesic. So which is the analgesic which you
For
advise?
long-term usage, probably we should try to discourage NSAID usage. The very idea of using a disease-modifying drug in rheumatoid arthritis is to reduce the NSAID usage. If you look at many of our patients who are on long-term disease-modifying drugs, they would be on SOS NSAID rather than a regular NSAIDs. But if it is a back pain, chronic disabling back pain, if the patient responds, paracetamol is a good long-term painkillers. And if they tolerate the drugs like tramadol, paracetamol combination could be used on a long-term basis, even 2 years, 3 years, on a safe basis, because they don't really cause renal, hepatic, gastrointestinal or major side effects. Except constipation, a little bit of sedation, they are reasonably safe.
What's your opinion about Etocoxib 90 milligrams or 120 milligrams OD for a long time?
Etocoxib is approved for 120 milligram usage only for acute pain. So don't use 120 milligram beyond 4-5 days, not more than a week at 120 milligram. If you have to use Etocoxib on a long-term usage with rheumatoid arthritis, moderate 90 milligram is approved dose, but preferably go down to 60 milligram long-term. 60 milligram OD or 90 milligram OD could be a long-term usage, and provided you monitor, you have screened the patient for the risk factors and you monitor them on a long-term basis.
Long-term means?
See, if somebody requires it, some of my ankylosing spondylitis patients would require it for 10 years. Would even require 10 years. But I would look at their creatinine every 3 months, 4 months to make sure that they are not, it is not deteriorating. If it deteriorates, I have to have another method of, I have to probably fall back on some other drugs like paracetamol or tramadol. If they don't work, we have to go to anti-TNF. It's a big problem. If I have an ankylosing spondylitis with a poor renal function, and if we cannot afford anti-TNF, we had it. Actually, it's difficult.
Thank you.
So, transdermally applied NSAIDs do really work in chronic pain.
Pardon, sir?
Transdermally applied, local application.
Yes.
Also captured of, you will commit some capsaicin might be. One more thing, in serotropinase we consider as analgesic in chronic cases.
Serotropinase, I was trying to get scientific information on it. If the scientific information seems to be very weak, it looks like it is one of the drugs promoted by institute. I never felt the need for it. Even when I had an injury and a big swelling, I took only one NICE or some whatever painkiller available at the time in my table. And we never required serotropinase. That's one. Number two is transdermal. It's an interesting question because there is a scientific evidence to say that transdermally applied diclofenac gel and few other NSAID gels which were used in clinical trials can be efficacy to NSAIDs or given orally at a lower dose. And it also has got a huge placebo effect. Opening a tube, applying the medicine over your own joints probably gives you kind of satisfaction. Probably why deny the patients of the satisfaction? So this can be, there's a counter-irritant action. Some amount of NSAID gets absorbed into the blood as well. We are not sure whether it enters in adequate concentration to the joint, but it seems to have a good effect. If patients respond to it, it is a useful method to use. Capsaicin is again, there is good clinical evidence, good scientific evidence, but in practice, using it, many patients are not happy using it because they have to apply it 3 or 4 times a day on a regular basis. Initially, it can have a very stinging, painful sensation. By any chance they forget and touch their eyes, they had it for the pain, irritation in the eyes can be very severe. So capsaicin has not really taken up as much as it should be, but otherwise it's a safe modality. Somebody uses it to their advantage, it is a useful drug.
Okay, can we have the last question?
Yes, sir. Sir, this is with respect to paracetamol, you said, textbook of pharmacology says more than 2 grams per day can cause hepatotoxicity. And you said 3 to 4 grams per day for 1 week in acute pain and 2.5 grams per day in chronic pain. In chronic pain means we may have to give it for weeks or months in some of the patients. So, which should I believe? Textbook of pharmacology says 2 grams is the maximum dose, or?
I would like to see which textbook of pharmacology it is. I have read enough pharmacology. I don't know. I can't comment because I have not read about it. But there is, if you read any recommendation Any American
Even
rheumatologist.
Goodman and Gilman says the same thing, sir.
Pardon, sir?
Goodman and Gilman from textbook of
I would
pharmacology.
like, I would like to go back and see, sir.